For those children, their life was determined in their first 2,000 days. We know that this is something that we learn, but I think it's something that far too often gets forgotten by those around us. Does anyone know the legal concept? How do you make this thing work? Of willful blindness. Just think about that for a sec just think in your own mind what willful blindness actually is, because it actually is quite important. It's not just a saying, it's a Victorian legal term. And what it is a legal premise is that knowledge you could have had, should have had, and chose not to have, you remain legally liable. And it is actually part of the law. And that's one of the reasons the Catholic Church is being inquired into at such great length, because of their willful blindness to what was going on. And they are held responsible, as are we, for the state of the inequalities in healthcare, that while we learn about the profession in the past, often has not done enough to redress. And this is all about you. This is about the future paediatricians and the practicing paediatricians. What can you do to change your practice to do something about levelling the playing field? But we know this. Last week's Lancet, an article from Dr. Taylor Hart. He died last week at the age of 89, but in 1971, he wrote a seminal article in the Lancet, before many of us were born, saying the availability of good healthcare, not of healthcare, of good healthcare, varies inversely with the need of the population for it. So in the last 47 years, what has actually happened to the equity of the provision of good healthcare? Well, in paediatrics, it's still extremely unequal, and probably no more equal now than ever. From the time you have the courage to identify your 3-year-old child as possibly having autism, and pluck up the courage to go to your GP to ask for a referral, you then have a 4-month wait just to see a paediatrician, just to be referred for the multidisciplinary assessment that they need. So 16 months just to get the care that is standard worldwide for children with autism. So what can you do about it? Well, the context of poverty is threefold. The first is poverty is defined by 50% of the average income. That's about 17% of all the children in New South Wales and in Australia. And then there is deprivation, whereas you lack access to the usual to the usual requirements of life. The family who can't drive their children to football, or can't play football, or can't afford football, even though it's the one thing that they're good at. But there's also social exclusion, and this is where community attitudes come in. And anybody who has not talked to anybody from the Aboriginal community doesn't realise that the social exclusion is ubiquitous, and it's everywhere, and it still happens every day. And the medical profession need to recognise that we are part of the problem. We are very much a part of the problem, because it's our attitudes that colour a lot of this, and the paediatricians and the GPs are the groups who are most able to advocate with the rest of our colleagues for what is good medical care. Because most of the 9 years in New South Wales difference in life expectancy between the Indigenous and non-Indigenous population is not statins, it's not diabetes, it's the lifestyle consequences of their childhood. So, what do we know? Well, 50% of the Exclusion is socio-economic: food, clothing, shelter. It is that simple. Just provision of those three things would remove 50% of the inequality. But the healthcare system is 25%. We allow, and we walk past a standard that we should not be accepting. For example, the ophthalmologists refuse to have anything to do with our children who cannot pay to see them. We don't call that out. We just accept that and throw our hands up. We don't raise anything publicly. And this is the reality that we're all familiar with. And the politicians argue all the time for equality. That's the one thing that they aim for, but equality is not fairness. Equality is often just purely resource distribution. And at the most basic level, the formula for health distribution of funds is often on a per capita basis, but not on a needs basis. And try, as I have, to get that redistributed on a needs basis, and you make some extremely powerful enemies within the profession. And I've made a few. And this is what actually happens. 4 months to get an appointment with a paediatrician if you don't have any money, a week if you are able to pay the AMA rate. The AMA chooses not to publish their rates. They don't want the community to see this, but in fact the AMA rate for a new consultation is $560, the bulk billing rate $220, but there is a disclaimer on their website: do not publicise this information. And the AMA is only 30% of the profession, by the way. They are seen by politicians as our mouthpiece, but only 30%. How many people here are members of the AMA? Yeah, a few, not many. So it's only 30%. And this is the distribution of speech pathologists in Melbourne. The blue dots are private speech pathologists, the green dots public speech pathologists, and the red areas of disadvantage, and the blue areas of advantage. So what are you going to do about this? This is about tracks in the snow. My career is nearly at an end. And just like tracks in the snow, all evidence of me ever having practiced medicine will disappear. The question is whether those tracks will disappear, or this current generation will try to do better than our generation has at reducing the inequity. And this stuff does matter, because the brain is developed by the age of 4.5. By the time you start school, it's nearly all over. And so this is up to us. We're the ones who have the knowledge and the influence to be able to do something about this. So this was my journey. 6 weeks before the 2007 state election, the then member for Macquarie Fields, a young man called Stephen Chater, was convicted of domestic violence against his then girlfriend. And so the Premier rang me and said, we want you to stand for the seat of Macquarie Fields. By the way, we'll build you a hospital at Liverpool if we get into government, which they did, I must admit. And so for 8 years I was a member of Parliament. I was a politician. I was inside the room. The most common question I get asked is there a big difference between inside and outside the room? And the answer is not much. Politicians and doctors are amazingly similar people. Just imagine your medical staff council. It's got your fascist orthopaedic surgeons. It's got your occasional lefty paediatrician. It's got a bunch of centrists. It's just like that. It is just like that. And the decisions have to be taken jointly. And if I can remember one thing about how to get ahead in politics, there is nothing more frightening to a politician than a doctor who has right on their side, but also has courage, but most importantly, has something that is reasonable, realistic, and they are persistent. Politics is the art of the possible, not the art of the perfect. And as Napoleon said, so it tracks in the snow because it's based on Napoleon. Know where you're going, know how you're going to get there, and take the people with you. You cannot achieve meaningful change unless you tick all those 3 boxes. And if you want a sustainable change to your department, such as the roster, such as the standard of care, everybody has to get a prize if you want to have a sustainable solution. The other thing I learned was don't work with children. That guy with the fingers behind his head is probably not recognised by many because history has forgotten him. His name is Maurice Yema, and he is the Premier of New South Wales. And that was taken at a photo shoot. But most importantly, if you have a look at those lovely kids, they are now 4th year post-school graduation. And that shows the changing face of Western Sydney, incredibly multicultural. These children need and deserve opportunity, and our greatest challenge is the fact that we've got 300,000 people in Western Sydney about to arrive in the next 15 years. 70% are already here, and they are those children and their children. So if anybody ever says to any of the registrars, who here's registrars by the way? Yeah. If anybody says there's no work, it is complete and utter rubbish. We're going to need every one of you forever. We're going to need every one of your skills. The question is whether you're prepared to do what the community needs of you, which is go where you needed to go, do what you needed to do, and stay. They're the things that will determine the future of your careers. So how do you manage in this maelstrom? So the first thing is, one thing politics teaches you is about managing people. And the one thing that is frequently forgotten, because it's a given in the medical profession, is not managing people. It's the one skill that kills people, and it's the one skill that you all need to learn, because a good team will always be the team of champions, and you will be the future team builders. And unless you put time into building your team, you will, as happens, be the subject of a very unfortunate outcome. A good example is last Sunday at Mount Druitt Hospital, the VMO on call did not even come in to see any of the patients. That is their workplace culture. These are public patients, these are poor people. They've just got a bunch of wheezing. Got a good registrar, which they did. I'm not going to come in and see them because I am just got other things to do on a Sunday when I'm on call. That is the standard that poor people get in the ring suburbs of Australia. An unacceptable standard, and if you don't call it out, and if you don't make that part of the workplace culture, that is a standard that will continue. Every child, when I went public about the Ballagata case, the lady who died, the doctor from England who was deregistered, I said, every child needs to be seen every day at consultant level, and every consultant needs to be available 30 minutes on call to see patient when they're on call, and that consultant needs to have skills able to deal with sick children. I got enormous flack from many of my colleagues about something that nobody in the community would even question. So this is the Aboriginal Health Service at Tharawal. That's where I work 1 day a week and have been doing for 25 years. The land was given to them by Campbelltown Council. This was built by the Aboriginal community. If you're serious about Aboriginal health, there is only one answer. If you try to do it, it's not going to work. The Aboriginal community have the skills and the need and the people who want to do it. Your job is just to be a facilitator. So they pay me $130 an hour for 7.6 hours. I bulk bill Medicare. These people are entitled to that. Some days I make the money, some days I don't make the money, but most of the time at least The funding is not an issue. For most of this 25 years I was working at Tharawal, there was no funding whatsoever given to me. It was given, the area health service paid my salary and I just told them I was going and get over it. And when I was a politician, I did exactly the same thing. I said, I'm working at Tharawal, guys, get over it. And I did it on a handshake agreement. It all comes down to one thing. Do you have the will to make a difference? If you don't have the will, it's never going to happen. What do I see? 49 out of the last 55 patients were there as a result of trauma. They were either on stimulants or risperidone. And the reason I was seeing them was legislative, because only I can do stimulants, only I can do risperidone for autism. This is the consequence of what's happened to previous generations, of the dislocation that's happened to their families. It is not glamorous work. I take a medical student and a quarter of the time they have to leave the room with the child, literally, so I can talk to the mother. Because I either have to say, for the 1 in 4 children I see in out-of-home care, 1 in 4 of the kids I see is in out-of-home care, 1 in 12 Aboriginal children is removed from their family, 1% of the state's children are out-of-home care. So the children out-of-home care, I often have to ask the carer, what do you know about the child? The answer is usually extremely little. Where was the child born? Don't know. When was the child removed? Don't know. About the only thing we do know is the immunisations, because you can check that. And out-of-home care is a lottery. It is not a solution, it is a lottery. And some people win the lottery and some people don't. Don't regard it as necessarily the solution. We have a new stolen generation. 1 in 8 Aboriginal children is in somewhere other than their family. So for 25 years, it has been incredibly rewarding. The sadness is that the one people who understood most about the death of my father some years ago was in fact the Aboriginal community, because they do death better than anyone else. It's been incredibly rewarding. You get to know people, you get to build up a relationship over time. You see, in terms of, they are the nicest patients you could ever meet. I see them, I dictate a letter in front of them if I can, and I send them an email with the letter in it. I don't write to GPs anymore, I write to the parents with a copy to the GP. And I try to repeat what they're saying, so they get an email 40 out, and they carry the email on their phone. So if they go to ED, they can just show them the letter saying, Dr. McDonald sees me, and they get admitted under Dr. McDonald if they can. Incredibly rewarding, not a lot of work, and some attempt to level the playing field just to get them into the care. And over time, we've now got an ENT surgeon, we've got an orthopaedic surgeon, we've got a gastroenterologist, we've got a neurologist, we've got a respiratory, but most importantly, I work with a bunch of GPs. This is the future of paediatrics, because I work with 5 embedded GPs. We have lunch together. My job is to bring the chocolate. If I don't bring the chocolate, they send me out to buy some. And GPs have got an enormous amount of skills to die for, and the most basic one is just asking about domestic violence. So I don't know how to, they don't teach us in the long case how to ask about domestic violence. They've got skills along those sorts of lines, and they teach you a lot, and they're good fun. And this is the future of paediatrics. The day of the VMO, sitting in their rooms, waiting for the people to be referred at AMO rates, it's not going to work. You need to become embedded in general practice, and that's where it's efficient and fun. And these things do matter, because this is what I do. Most of what I'm doing is above the age of 6. Food, clothing, and shelter matters below the age of 3. So, what's in it for you? Work. All the Aboriginal Health Services are keen for paediatricians to just ring them and say, my name is so-and-so, I can come down. Are you indemnified? Yes, they are. Do you want me to come down, bulk bill your patients, take GP for referrals, and I can do it once a week? I don't know of any Aboriginal health service who wouldn't die for that. The paediatrician going to Moree who's fly in, fly out is 76 years old. We need the next generation of paediatricians to say, well, I can do that. And you need to, because this is an email this is last Thursday's email. It was actually, I had to, don't forget the bubbles people rejig my slides. So it's actually McDonald, but this is what we deal with every day. So the take-home message, our generation has done really quite poorly in levelling the playing field for sick children. Most of what needs to be done requires you to do only one thing, which is make a decision saying, I choose to do something to level the playing field. There's a big community who are very keen for you to do what they need you to do, go where they need you to go, and to stay. Thank you.
Thank you, Andrew. That was great. If not a little daunting, what do we have?
So thank you, Dr. McDonald, for sharing your wisdom, knowledge and experience with us. I think you've captivated a lot of the audience. We don't have too many questions on Twitter, but we saw some registrars in the audience, as well as there's a few of us junior doctors floating around. Do you have any advice for how we can begin to become involved in helping?
Yes. Number one is there's quite a few paediatricians who go to places like Tharrawell. Come down with us. So, I'm down there every Tuesday. We're very keen to have registrars come down. So there's often opportunities. This is not something you'll ever learn in your paediatric training, because you either do it in child psychiatry at the highest level, or you do it in ED. So this is an opportunity you've got. So search out the various paediatricians who do go and offer to come down and help. We always need someone who can listen to a heart, take blood pressures, just be there. So there's an enormous capacity for paediatric training. And the College of Physicians say stuff, but for 20 years I went there, or for the first 10 years I went there were no GPs. I was just seeing unreferred patients. And so sometimes you need to be prepared to break some rules.
I love rule breaking. Is there any questions from the floor? Yep. Can you jump on the mic, please? Can we turn the microphone on, please? Oh, might just need it on the button up the top. It's like the IT crowd. Have you tried turning it on and off? Thank you. That's all right, Hill.
Thanks, Andrew, for that. That was really good. I still remember you pretty much got me through my exams, so thank you for that. You'd failed a few times, and I'd failed at least once, and you got me through, so that was really good. Look, I don't get much of a chance to talk to people who've been in politics, and I'm from New Zealand, and my brother's a cardiologist in New Zealand, and we work in quite different systems. If you had ultimate power and you could do anything you want to fix the health system, what's the problem? I've got VMO mates that see working in the public system as being community service, and they make ridiculous amounts of money, but they don't see the public system as being where they want to be. They want to work in the private system. What do you think? What would you do if you could fix a problem? Is it Medicare? What do you think you'd need to do?
Tell the truth. 10% of all patients have adverse events. Tell it early. Publish it literally the next day, like how many beds are actually available, what's the bed occupancy, and tell it yourself. Be prepared as a politician to tell it yourself. The bureaucrats are actually quite keen on telling the truth. It's the politicians, and transparency would include the publication of the salaries of the VMOs. For example, the public knows stuff. If you get the public involved, they're far better than the doctors, and it is the doctors at working stuff out. So tell the truth. Tell the truth about the health system, and you'll get far better health care.
That's never going to happen, though, is it?
It is more likely to happen now that the Bureau of Health Information was set up some years ago in New South Wales, where a lot of the statistics are being rolled out. It's better than it was, but there's still a long way to go. And the problem is not the bureaucrats are not that opposed to it. It's the politicians who've had a problem.
I think we could probably go on all day, but we're going to have. I don't want to cut our the speakers short. I think how I'd like to summarise is just to remember from little things, big things grow. So don't try and change the world, try and change your world. People in front of you. All right, thank you, Andrew. Please join me in thanking. It was a terrific talk.